think we're here today to try and inform as many veterans as we can. We're here with Dr. Bash.
Welcome, Radio Land, TV Land, and YouTube viewers and listeners. This is Dr. Craig Bash. I've been doing veterans medical opinions for 30 years, and I have dozens and dozens of these radio shows which we're going to publish on this YouTube channel, and number 1 through whatever. So thank you for listening, and here we go.
Hey, we're here today with our co-host, Jay Basser, and our guest speaker today is Dr. Craig Bash. He's a Veterans Medical Advisor. So if you have any questions or comment, feel free to call in. Our number is 347-237-4819. Now that number once again is 347-237-4819. And then you'll hear some lady talking. Just hit 1 while she's talking or after she talks or whatever. That'll bring you in the queue with us. So feel free to call in. How you doing today, Dr. Bash?
I'm doing good. Hey, I'm kind of worried about this new VA process and where they're going to try and process claims. You know, my biggest concern is,
yeah, we've been talking about that for a good while.
Yeah.
It being new, it's always of a concern to me. It takes them so long to get the bugs worked out of things. And is it even feasible? Who knows? Are they going to make the process better, or are they going to make it worse?
Yeah.
It's just
the big thing I worry about is trying to put in new evidence. You know, it's like one of those pathways talks about how you can go for a higher level review, but you don't get to put new evidence in. You know, and then so new evidence would be like my medical opinion or the new medical data and so on. So not having new evidence could really hurt the claim because oftentimes the veteran doesn't know what he needs, and medical testing gets better over time, and so on. They have a better chance of success with more evidence, I think.
What I run into, Dr. Bash, all through my claim, they were sitting on the evidence that I needed, and by the time I'd get my hands on it, it would be several years down the road, and then I'd have to submit it, and it coming from the VA. And to me, that's problematic. When they mention that you can't put in new evidence, many times it's years before you know it's there. Of course, they can never find it. You have to give them the page number and everything else. I mean, you got to nail it down for them, put it in their hand before they'll consider it. With medical evidence, such as what you provide, that's a little different, but the evidence in your records, because they won't go hunt for it. And even if you tell them it's there, they'll just say they can't find it or it don't exist. And when you realize it really does, it could be 5, 6, 7 years down the road.
Yeah, and some of the VA people have told me that they won't let them do new testing. Like, in the old days, if they had a question about some issue, like if they needed a chest X-ray or they needed an expert opinion, they go out and get it. But they've told them now if there's no, if the evidence isn't there, just deny the case. And if they won't allow new evidence, it makes it very difficult for the veteran to be successful, like you're talking about.
Oh, they won't be successful. Unless they get a VA doctor to work with them, which is that's not very likely.
Yeah. So my philosophy now is I'm trying to do a lot of these cases with the evidence up front. So like in the old days, I might write an opinion and say that this was this way because of this reason, and that we might need a certain test. So what we do now is we're trying to get the testing done ahead of time. Like I might get a podiatrist to weigh in. I might get a neurologist to weigh in behind me. I might get a pulmonary doctor. So by the time the claim's ready to put in, I have my opinion, plus I might have 3 or 4 of the doctor opinions behind me with all the needed evidence,
Well, the way it's structured now, I can see that that's about the only way you have to go, isn't it? You got
that way.
to put
And
it
the other
in.
thing,
Yeah.
Yep, try and get it in up front, right? Which is hard because the veteran, it's costly and so on, time consuming. But the other thing is that they might have that thing called a supplemental appeal. If one of those pathways has a supplemental appeal. So I think the supplemental appeal, my thought was that in the supplemental appeal, I might do another medical opinion with a new medical test. Like I might order a new chest X-ray, or we might have a new, pulmonary function test or something like that. So it would be relevant. Because the VA is going to say if it's not relevant, they're not going to admit it. And then another way to do it would be to get a second physician behind myself to have two-way opinion. So Dr. Bash says this and Dr. Jones says that. So that's another piece of new relevant information, which would allow new information to get into the file. I guess you can do that like 3 or 4 times, and then after that's over, if you're still unsuccessful, then you got to maybe wait until the BDA, which could be years, like you're talking about, 6-7 years.
Yeah, that's unfortunate too, because if the VA would really honestly work with a veteran, they got his doggone file, and they know what's went on. They shouldn't have to depend on the veteran to tell them, dig it out themselves somehow.
Yeah.
And they
these Raider guys
out.
told me,
Go ahead.
These Raider guys told me they're trying to do things so fast that if the Raider asks for information and tries to get tested, it slows the case down. So they're trying to put the workload on the patient, which is not right. That's what you're saying.
Yeah, and that's what they're doing. And many times a patient, they don't remember years back, or something could have happened. It might be in the records. And I have found getting a proper claims file out of the VA is really difficult. I went through 5 different claims files. They put on CDs for me, and each one gets larger. And
how does that work? Well.
And here, this is additional information could have been utilized from the get-go.
Yeah.
It's there's something seriously wrong with that. You should have a real-time claims folder that you can look at. Now, I know they have them for some of the BSOs and stuff, or claims practitioners. They can get that access, and lawyers, but a veteran can't get it.
Yeah, because once the veteran gets it, they didn't get to some expert like myself. Secretary McDonald was very good at that. We used to write a letter to him, and he could get the claims file in a couple of days, and he'd FedEx it out on a disc. But the VA can do that if they want to, but they don't really seem to be not invested in that process. A lot of the data inside the records is not being looked at. You're right. So that's one of those things I was going to touch on a little bit. CUE Bill Krieger wants to come on in a month or so and talk about CUE in a deep way. But some of the examples that I find on the medical side is that they don't understand the terms. Like somebody will have a little fracture in their spine called a pars defect, and the Raiders will go by it and don't realize it's a spine fracture. That's a CUE. Or things like reactive airway disease, they'll miss reactive airway disease. It says RAD in the record, and it's a precursor for asthma. So, or they'll miss some of the stuff with the nerve distribution in the hands for spinal cord. Confuse the C6 and C7 roots. Bill's got a good case on that. So, not only is the record not maybe presented as well, the Raiders aren't looking at it as carefully as they could, to find these details that can make a big difference in the case. And that's all about trying to do these cases. I heard they're trying to get Raiders to do cases in 30 minutes now, really pushing them fast to get things out the door, work products. So a lot more sloppy evidence.
Well, they sure ain't done mine in 30 minutes. But anyway, it's a new process, Dr. Bash, and it's got to be proven up. and if they can't prove it up, and pretty soon we're going to find out, because when everything is piled in this, what's this new process? I keep wanting to call it fracking, but ramp. But it'll all, like when they claim they made such a headway on the claims process, it all went to the appeals. And I think that's what you're going to see here with the fracking program, ramp program, is everything's going to pile up in the ramp program, and they're not going to be able to meet the timelines that they've indicated. That'll tell the tale.
Yeah.
And I understand they're already getting behind rather quickly.
Well, I saw a case last week that came through. They're already starting to talk about the relevant evidence. They said that the information that was presented wasn't relevant, so they're gonna discharge. Like the veteran puts in redundant evidence or puts in literature and things like that, they're just gonna say it's not relevant and push it back. So that relevant evidence is going to be an interesting definition.
Well, that could be detrimental to a veteran for sure, because I can certainly understand there could be relevant evidence out here, articles, newspaper articles, or you run across memos, all sorts of different things. I mean, the list could go on, I imagine. Just because the rater don't think it's relevant, don't mean that it isn't.
Mm-hmm. Yeah. The raters are being pushed a lot on that M21 too, and Krieger was talking about that a little bit. He said that the M21 oftentimes doesn't relate itself very much to what the laws are. So the VA kind of makes up their own kind of internal rules and puts them in the M21, and the raters follow it, but they're not really necessarily backed up by the legislature, So
I've had arguments with them, and say, look, if you just read this thing, here's what it says. And they say, oh, no, that ain't my interpretation. And it'd be something, so obvious that it's crazy. But the ramp program, I think, will show its ugly face here in 6 months, less than a year. It's going to be so, like I said, there'll be 500,000 behind there. They're waiting. And they're just changing names of the same problem. They're just giving it a new name.
Yep. So Jay Baxter wanted to talk about, he said something about vascular things, right, Jay?
Yeah, I'll speak in vascular. Yeah.
Cardiac.
A little bit of heart disease and a little bit of PED, things like that, peripheral artery disease. It's kind of, generalized discussion on that, those issues. I mean, there's a lot of vets that got these issues, and a lot of them don't realize they got it. They don't know what's going on, so.
Well, one, we have to think about etiology. One etiology is something that's toxic in the blood vessels, So we talk about, Agent Orange, or talk about maybe diabetes with high sugar levels, So those toxic things can cause the vessels to react in an inflammatory way, and so that's why you might have ischemic heart disease where the vessels get narrowed, and you might have basically ischemic changes in the legs, peripheral artery disease, arteritis obliterans, and so it's kind of the same common pathway. And I'm sure, I haven't looked at it closely, but we know diabetes causes changes in the brain, and so even though it's not well rated, but you could get things like dementia, and these mini strokes could be all due to those same kind of vascular changes, in the brain. So then the end organ kind of responds the same way. When you don't have enough blood to whatever organ it is, it starts to lose function. So like in the heart, you might get, angina, chest pain. In the legs, you might get this thing called claudication, where you walk a certain distance, So then the VA tries to, go ahead.
Is there any treatment for that if you got like hardening of what they call hardening of the arteries, especially in your legs? Is there any special medication a person can take?
Yeah, well, it all kind of depends exactly what the cause is. If there's lots of ways they get sort of overlapping problems. So if you have high blood pressure, that can cause some arterial narrowing and the hardening of the arteries classically. And if you have high sugar, that can cause problems. If you have toxic exposure, that can cause problems too. And those things, so you might have sugar, you might have all three of them. You might have sugar, you might have some Agent Orange, you might have some blood pressure. So if you can treat part of them, get the blood pressure down, maybe fix your cholesterol in some ways, get that corrected, and then some of that stuff can be reversed a little bit. The toxin stuff from Agent Orange is probably a little bit more sort of concrete, not as reversible, but the body's always trying to make things better. So if you can optimize the environment, there's no real magic bullet. If you have a real single narrowing, that's where you get those stents, and they do vascular surgery and put new vessels in to try and correct that stuff. But a lot of this can be chronic.
What about it gets so bad your feet go numb? I know several veterans that they claim their feet went numb. That's a serious situation, isn't it?
Yeah, it's a huge problem. The vessels, there's little small blood vessels, vasa vasorum, that run along the side of the nerves. So when the blood vessels start to get, so when the blood vessels start to get damaged, those little vessels that supply the nerves get damaged, maybe even early, and then you get those problems with the nervous system. You get that peripheral neuropathy from different causes. You get numb feet, and you have loss of balance, and you may have use a cane, you may fall, and you may get yourself into high levels of SMC based on loss of use and loss of balance. And, not even amputation or spinal cord, it can be based on peripheral neuropathy. And, it's a very serious. You can cut your foot off, you can burn it, you get infected. People can die from all those secondary complications.
Oh, that's serious. Yeah, it makes it's not really possible to go in there and do what they call rotor rooter, or go up there and clean the plaque and stuff out, because if you chip that plaque up and it starts breaking loose, of course it could cause a stroke. Or worse yet, it could kill you.
Yeah, stroke. If it's in the legs, you get a stroke in your leg, you might lose your foot, And the plaque, it depends on what the process. Some processes are continuous, like a freeway jam all the way down the freeway, and other processes are more like a bottleneck at an intersection, So if you fix the red light, you can fix some of those different things. That's why we do imaging and angiograms to try and find out exactly what's going on there. We can try and tailor the treatment, But the VA rates those things. They kind of rate them. They kind of rate them both. Krieger's not here as a rater expert, but they kind of rate them on function. Like in the legs, they talk about the claudication, the pain that you get over a certain distance. They measure like 100 yards and give you a certain number. Then they also measure it based on this ankle brachial index. They take the blood pressure in your wrist and compare it to your leg, and they should be pretty close, even though it's a little bit different distance. And if that index is less than 0.9, they can give you a higher percent, like 20%. Same thing in the heart. If you have ischemic heart disease, then they'll rate you based on METs, metabolic units, and so you can measure that by how far you can walk or if you can climb stairs, and they'll give you different levels. There's a little chart you can look at, or they can put you on a treadmill and measure your oxygen and try and get an idea of what's going on that way. Anybody who has chest pain, any patient has chest pain or leg pain when they exercise or work out, that should be an indication that they might have these places where the blood's not getting to that organ, the leg or the heart.
Okay. Got a question, Dr. Bass. Now, what if you had those symptomology, and you have that, but say your cholesterol, you have it checked regularly and your cholesterol's in good shape, you know, you've been taking some anti-statin medication or whatever.
Yeah.
What would be the factor in that issue?
Well, you could look. You're trying to separate cholesterol problems versus the problems you might get from Agent Orange or diabetes, right? What you're talking about? Trying to split out those processes. Yeah.
Rule out.
So, So it's like a process of elimination. So, if your cholesterol is good and it's been good, then that might be a less likely problem. But then you can check the blood sugars and see what that's like, and then check like what the toxin history is. Check the blood pressure, and then you can also, you can do some manual testing where you measure the pulses in the leg and see if they're normal. And then, if you're confused about it, you can get that test, that ankle brachial index test, and see how that works out. If that's low, then you have, sometimes you get in a situation, oftentimes actually in medicine, where you have two processes that can give a similar result, And so in a case like that, I always, tie goes to the veteran. So if I would say something like the patient had some high cholesterol, but now it's under control, and we know that cholesterol could contribute to this process, but we also know that he's exposed to TCE or Agent Orange or has diabetes, and that could also do it. And so, in my opinion, it's impossible to tell which one was causation, and the veteran should get credit for either one of them.
How would 35 years of uncontrolled hypertension fit in the mix?
Yeah, same thing. High blood pressure causes the same kind of deal. It causes those arteriosclerosis damage. The blood pressure damages the intima of the wall, and then the intima gets a little bit damaged, and then the plaque can stick to it, like, if you have high cholesterol. It also depends on the size of
sandpaper.
Yeah, exactly. It kind of depends on turbulent flow, like in places where you have intersections. There's a lot of turbulent flow, and that can cause the plaque to build up, like the bifurcation in the carotids is a classic place. We have turbulent flow. And and that turbulent flow also is what causes the aneurysms to form oftentimes in those junctions, because it makes it a little bit weak there. The chronic hypertension can be a contributor to it. The size of the particles makes a difference too. So they're starting to do MRI scans, so microscopic type of MRI, measure the size of the particles, and it turns out that not all the cholesterol particles are made the same, and some are kind of fat and juicy, and some are kind of small and thin, little. And so they talk about the LDLs or smaller type particles, but there's even some breakdowns in those. So what happens is the small little particles can get through the wall of the vessel. So if you have that turbulent area or you have some, damage to the wall, the little small particles can get inside there and start to build up the plaque in the subintimal area. Whereas the big fat little juicy ones, like, they might be like dump trucks. They just kind of roll by and they can't get in. They can't get in and cause damage. So it's not just the raw number of particles, also it has to do with the size of them. So that's why if you take different types of medications or even vitamins, you can change the particle size. And then when you do that, then you can actually start to change the vessel. You can get some reversal of some of that stuff.
Well, that could actually affect your brain if you started getting plaque build up in your brain.
Yeah. Anything that happens in the heart and the legs is going to happen in the brain. It might not be quite as obvious. But on an MRI scan, we see a lot of that. Like if you take an MRI scan of somebody who's had diabetes for a lot of years, you'll see a lot of these little tiny areas of increased T2 signal, which can be caused by hypertension and often diabetes. And you get little microscopic damage to the brain that you don't really know about. And that may be part of that aging process where the brain doesn't work quite as well or the memory's not quite as good. It might just be these small little changes in the brain that have occurred because of, the blood vessel pathology that we don't really, pay that much attention to maybe in the brain.
Wow. Looks like it's a rough way to go. But most of that can be service connect. If you can evidence exposure to something or Agent Orange or whatever, it can be service connected.
Yeah, and it's good because service connection is part of it. You get benefits for rating decision, but also, that service connection process helps people identify, in the hospital, because, a lot of these patients now are being cared for by nurse practitioners and PAs,
Yes.
So those guys aren't going through the detailed analysis to try and find the root cause oftentimes. And so if you get service connected for some sophisticated process, say maybe you have TCE in your brain that showed up as these changes, and that gets in your medical record, and then the nurse practitioner and the PA goes along and can see that and can read about it and then try and think about how to treat it. They're not going to necessarily find it, but they might be able to treat it a little bit if they know that it's there, you know what I mean? So it could change your whole way of being treated based on your rating.
Well, that's right. If they know what the symptoms are, like you say, they may not know exactly where it's at, but I would say if the guy's foot is numb, it's bound to be in their leg somewhere, or even at the foot, or, various locations there. And if they're giving them, treating a symptom with some sort of medication, I don't know what kind of medication they treat it with, but I would suspect you'd know pretty quick if you started getting feeling back that they were doing the right thing.
Making an effect, yeah. Yeah, part of the problem is that the visits are so short now, too, so you have a nurse practitioner, a 15-minute visit, and the patient comes in with, they might have high blood pressure, So the whole visit is rolling around and talking about the high blood pressure, whereas the patient also had on his list the numb foot, like you're talking about. Well, the numb foot, I see case after case now where the patient goes in with a new medical problem to a medical visit, and the doctor and the nurse practitioner and PA just ignore the new finding. Like the patient will say, "I've got a numb foot," or the patient will say, I'm not urinating very well. The patient will say, "I've got blood in my stool," or whatever. And the doctor and the nurse practitioner, PAs are just ignoring it, because if they acknowledge that problem in the medical record, and then they don't work it up, with a 2-hour workup and do a bunch of testing, then they're like liable for malpractice. So they're just treating the one problem the patient comes in with, and they're really ignoring the other new issues. It's crazy bad medicine. Crazy bad medicine.
That is bad medicine, and I've seen that. I've seen that very thing, because I've told them at the VA, different things, and they just go right over the top of it and keep going.
It's not the VA only.
No follow-up.
Civilian sector is doing the same thing because it's the short visits, And it's actually being propagated in the medical schools, because I've had medical students tell me that the resident told them when the patient comes, they only deal with one problem. They only deal with one problem and get them out the door, So that's becoming a systemic problem throughout all of medicine, and it's not, it's just not very good. Even the guys who do stuff like I do, the ratings, the medical opinions. Like I had a guy today that went for an opinion, and the guy gave him one issue, and I had like 15 issues I picked up, and some of them are really spine, things that he has that he's got to get rated for. Thank you all for listening. That ends this show, and now I'm going to zoom off.